All right. Well, good afternoon, everybody. Thank you guys for joining us. This is our February 2026 Rover session. We have an incredible lineup today. My name is Troy Kleber. I'm a resident at MD Anderson. I'm one of the Rover moderators. And today's session is going to focus on non-traditional brachytherapy. We're being sponsored by a number of organizations that have been helpful in helping us coordinate and marketing this session. Of course, ACRO is one of our big sponsors, a big partner of ours for Rover. ABS is a sponsor, American Brachytherapy Society. We're very grateful for their help. And Gametile, which is very relevant to the topics we're going to talk about today. They are also a sponsor of today's session. So we really appreciate the sponsors. We have an incredible lineup of three speakers that are going to touch on three different topics related to non-traditional brachytherapy. Dr. Thomas Beckham at MD Anderson will focus on brachytherapy for CNS malignancies. Dr. Garant at UT Southwestern will focus on lower GI malignancies and brachytherapy, and Dr. Nagavi at Moffitt will talk to us about sarcoma brachytherapy. Without further ado, we will get started. As a reminder, we'll have some time after each of these talks to get into some questions that you have. You're welcome to throw those questions into the chat, and we can get to those questions, once the talk is over, or at the appropriate time. You can unmute yourself and ask your question at that point. So we love audience participation. This will be a cool discussion here today. But let me proceed with the next slide. This is me. I'm Dr. Kleber. I'm going to be moderating today, and I'm passing the mic over to Dr. Beckham, who will get us started.
All right, thanks, Troy. So I'll be talking about technically Gametile, but I try not to use the brand name despite the sponsorship. Cesium-131 collagen tile brachytherapy for CNS, I guess metastases. I'm not sure if I put any glioma cases in here, but let's go to the next slide, which I think is a relevant disclosure slide. So FYI, next slide. So we'll start with a case. This is actually my very first Gamma Knife case as a young attending. This is a woman who was undergoing chemo, adjuvant radiation therapy after neoadjuvant chemo radiation therapy and mastectomy for triple negative breast cancer. As you may know, the chemotherapy for triple negative breast cancer can work quite well, but it doesn't tend to penetrate into the CNS. So this isn't a terribly uncommon situation. She had some vague visual symptoms that were probably unrelated, but got a brain MRI and was found to have these two brain metastases, which we treated with Gamma Knife radiosurgery, 20 grain a single fraction. Next slide, please. And so, of course, we follow these patients afterwards. Small lesions like that, I would expect a very high success rate with radiosurgery, and she did have a good initial response, 8 weeks follow-up. At 4 months follow-up, however, we're seeing some changes. At this point, it's pretty non-specific. You can see that hypointensity representing some edema and that the lesion has increased in size. This could be necrosis, this could be tumor. We really don't know. So next slide. So when you're thinking about a patient who's had SRS, I think for single fraction radiosurgery, I tend to quote very similar risk per lesion. I think the risk that you have a local failure after single fraction radiosurgery is very similar to the risk that you have radiation necrosis. For a lesion like that, I would say something like 5 to 10%. And we make these determinations using imaging. I think that the structural MRI is really the most useful scan. That really tells you the story, but we also use perfusion sequences and MR spectroscopy, as well as potentially a delayed time point PET in equivocal cases to try to make a diagnosis between treatment-related changes, radiation necrosis, or tumor recurrence. Next slide. So this is what we call an ABTI. It's our combination of perfusion series plus spectroscopy. And in this case, this was, fairly equivocal. I would say at this point, this kind of looks like tumor to me. It's got sort of a nodularity to it, but it's not totally specific. But really, reassuringly, there was really no perfusion seen on this, the DSC scan representing sort of the total amount of blood volume within a target area. So that was reassuring. And the spectroscopy was also not very useful in this case. What we're kind of looking for when we're looking for tumor is a peak in the choline relative to other peaks like the creatinine in the normal brain. There's also not much of a necrosis peak here. The lipid lactate peak occurs after, or I guess more towards the right on the screen of the NAA peak. Really kind of a bland ABTI in this case. So next slide. So you keep watching and you see what happens, and eventually you sort of things clarify over time. Now you can see this lesion is larger. It still has that nodularity to it, not totally specific looking based on the contrast enhancing scan, but there is some blood flow through it, and you can see, especially compared with the prior, that there is more of a choline peak. So we were at this point pretty concerned that this was tumor recurrence more so than just necrosis. Next slide. Just pointing those things out. Yeah. Okay, there's a poll question here. So, what's the standard of care for recurrent brain metastasis after SRS? Whole brain, CNS active systemic therapy, repeat fractionated SRS, surgical resection, or lit, or there's not really any standard of care. All right, let's see. Okay, yeah. So most people picked what I think is the correct answer, which that there's no standard of care, and that's certainly true. There are lots of options, but there's no standard of care. So the next slide. Options for this case, we mentioned them there, so I won't go over them again for the sake of time, but let's go to the next slide. Yeah, you really have to just click through these things, Troy. Thank you. So you have to think about a lot of things. How many lesions are recurring? If 10 lesions are recurring, obviously you have a different situation than if one or two are recurring. We do consider surgery in the case of a recurrent brain metastasis after SRS. So are they a surgical candidate? Are they developing other new lesions such that they might need whole brain radiation therapy or something like that? Are there any systemic options that might reliably help in this situation for this patient? We're fortunate now to have more CNS active systemic therapies, but not in every case. And what's the situation overall? This patient, is this patient hospice bound, or is getting control of what's going on in their brain still a meaningful goal for them? Next slide. Yeah, click through those. Yeah, so the in this case, the patient had one lesion recurring. She was a great surgical candidate. She had no other new lesions. She was NED otherwise, actually, and for triple negative breast cancer, or even in that scenario in general, I would probably lean towards local therapy again, given this was her only site of disease. So she got surgery, and this is what her postoperative scan looked like. Next slide. So I've come to believe that if you go through the trouble of doing surgery for a tumor, you should think about doing reirradiation again, even in the setting of having prior radiation, such as a case like this. This is a series from MD Anderson looking at SRS failure lesions, so lesions that have recurred after SRS that then got resection. Even with a gross total resection, recurrence rate is very high. It's actually very similar to if the tumor was de novo treated, where we always do SRS afterwards. But of course, we're concerned about balancing the risk of necrosis in the setting of irradiating something a second time with the value of local control. So recurrence risk remains relatively high. So what can we do about that? Let's see, next slide. So we didn't actually irradiate her afterwards. We don't have great data to support reirradiation in that scenario, but and at the time, we just decided to observe. Unfortunately, it did recur. So you can see in this middle image, this is sometime after she's having that nodular tumor-looking enhancement there that I think is definitive for local recurrence in this setting. So we treated her with 9x3 post-op, or I guess early salvage SRS. Next slide. Unfortunately, this failed again. This tumor continued to grow, and it had more signs on the ABTI that it was indeed active tumor. So we reviewed the same kind of questions that we think about before. This remained more or less the only problem this patient was having from her cancer. So all those answers still pointed to it's meaningful to get ahead of this. So that brings us to our sort of last option in a scenario like this, which is cesium-131 collagen tile brachytherapy, at least in my practice. So this is what these are. This is a product that is made by GT Medical Technologies and branded GammaTile. It is a collagen resorbable matrix, about the size of a postage stamp is what I tend to tell patients, that has some design features that I think can make it very user-friendly and advance over prior options for brain brachytherapy. There are 4 cesium-131 seeds. situated, as you can see here. And importantly, there's this 3 millimeter offset from the bumpy side, which tends to go towards the brain, and where the seeds sit within the tile. In the middle, you can see an example of a case. So this is a craniotomy where a cavity has been made, and you basically line the at-risk parts of the the cavity with the tiles, and then you end up with typically a fairly good dose cloud that's meant to prescribe 60 gray to 5 millimeters depth. Next slide. Um, this has some design advances, I think, as I mentioned, over historical methods of just using free seeds, where you actually place the source directly against brain parenchyma, which means it's going to be very hot. We know like about the inverse square law and the fact that we have very rapid dose fall with brachytherapy, which is an advantage. But when you're putting the source on the tissue, you have hot spots, and some historical approaches, I think, have caused high rates of radiation necrosis. That little bit of space, I think, reduces that issue, and it also has them, having them spaced uniformly within the tile means that seeds aren't going to overlap with each other and produces a more predictable dose distribution. This does cause, I think, sorry, go back. This is dose escalation at the cavity surface. So the 60 gray physical dose at depth is sort of similar to 9 gray times 3 fractions, which is a common radiosurgery dose. But if there is a little bit more radiation, we get more like 80, 90, sometimes 100 gray at parts of the parenchyma at the surface of the cavity, which, if safe, is probably a positive thing for tumor control. We also start radiation right away, which is convenient for patients. Not have an additional procedure and potentially for tumor control. And it, of course, ensures treatment compliance, which can be an issue for patients who may have trouble coming back for adjuvant therapy. Next slide. So this is what this looked like. So this was the second resection, and you can see the pink is the tumor cavity that we outline, and then you do post-implant dosimetry with a contrasted MRI as well as a non-con head CT to identify where the seeds are. And you can see the at-risk area is covered pretty well by the 60 gray line, which is the red bolded line, and that's the intention. Next slide. So this has been a very interesting patient. I didn't tell the full story, but I think this is a patient who had what I call tenacious CNS disease, just really specific lesions that cause problems over and over. But we do have it under control after 5 years. She remains NED from her cancer otherwise, and had a very similar course from the other lesion. So there's something intrinsic to her biology that made her radiation resistant. So she's had surgery and GammaTile to both of those sites with some other interventions prior. She did end up getting grade 3 radiation necrosis in one of those sites, which was resolved with surgery 4 years after initial treatment. But she's, all things considered, I think, doing fairly well. Next slide. This is some data that we have for recurrent brain metastases with the use of GammaTile. There are a few different series out here that are sort of summarized here in this table. And I think that local failure rates are very good. They're probably better than repeat fractionated SRS. And there's something intuitively attractive to me about using a different radiobiology in the setting of a lesion that's already failed radiosurgery. There may be something advantageous about exposing to a different radiobiology. So in our experience, we had a cumulative incidence of local failure at 12 months of 13%. And about 8% radiation necrosis. So in the radiation setting, that's fairly good. We were able to identify some risk factors for local failure. On univariable analysis, we don't have sufficient cases, fortunately, to make multivariate estimates. But having more than one prior RT course, a larger pre-op tumor volume, a subtotal resection, and lesions with extensive dural contact would get you onto this line. So there's a higher risk of recurrence there. But for simpler lesions, the local failure rates are 0 in our hands so far. So that's unfortunate. I'm knocking on wood on my desk. Okay, next slide, please. So this is not for me to go through, but if you're interested in my like sort of NCCN flow chart style advice on how to think about cranial SRS failure, you're welcome to take a screenshot of this and use it for a reference, but it's much too much to go over right now. Next slide. Okay, I'll try to zoom through this. I know I have too many slides. Troy told me already. So this is a 65-year-old female who has 2 to 3 months of minor balance disturbance and worsening headaches. She's a significant smoking history and has had a cough. She's been losing weight unintentionally, so she's seen in the emergency room. Next slide. and has this lesion, well, this edema and anomaly seen on head CT, which is what you'll typically get first. And then she had an MRI, which shows this enhancing what looks very much to be like metastasis in a patient that sounds like she has lung cancer. Next slide. This is her systemic imaging. So she's got this right-sided lung and lesion with mediastinal lymph nodes on PET. So looks very much like this is a lung cancer with a metastasis to the brain. Next slide. So she had a biopsy. It's adenocarcinoma, likely of lung origin. Next. Let's see. Okay. Poll question two. So the Alliance study, I call it N107C. Paul Brown is the first author, published in Lancet Oncology in 2017. Established the standard of care for this patient, which is postoperative SRS as of recent years, based on what primary endpoint? We can scoot along since we're probably running low on time. It's actually, I think it's a trick question. It was a co-primary endpoint of overall survival and cognitive deterioration-free survival. Cognitive deterioration-free survival was met. Overall survival was not. This really reflects a different era of thinking about brain metastases, frankly, because at the time this trial was designed, there was legitimate concern that omitting whole brain radiation in patients with brain metastases might actually do them harm by causing them to be at risk for future brain metastasis events. We now don't believe that's true. Nevertheless, the study was considered successful because of the quality of life endpoint of neurocognitive superiority with SRS. Next slide. Over whole brain. So this patient was enrolled on ROVES. This is basically GammaTile versus postoperative SRS, a randomized phase 3 study that's completed accrual and has some initial data reporting. So she was enrolled in the study and randomized to get GammaTile. This is what the case looked like. Very nice coverage. What we're looking for is the 60 gray line, and we have quite good coverage in here. There's the DVH. Next slide. And this is the interim analysis of Rhodes, looking at the primary endpoint of surgical bed recurrence-free survival, which was significantly better. Surgical bed recurrence-free survival was 11.7 months in the post-op SRS arm versus 42.5 months in the GammaTile arm with a very nice hazard ratio. So the trial was already complete in terms of accrual at this time. It would have triggered early stopping rules. So we are going to have the final analysis or the full analysis at ASCO this year. I don't know what it is yet, but if it holds up, I expect GammaTile to be probably the preferred standard for unresected newly diagnosed brain metastases undergoing resection based on this interim analysis. So next slide. Okay, hopefully I didn't go too far over time, but if there are any questions, I'd be happy to answer them.
No, that was perfect, Dr. Beckham. We do have a couple minutes for questions. Feel free to unmute yourself or throw it in the chat if you have any. Well, I have one question, Dr. Beckham. I know you spent your talk primarily focusing on brain metastases and the role of brachytherapy and GammaTile. I know there can be also a role for brachytherapy or GammaTile in the context of primary CNS malignancies. Do we often think about that similarly? When you're thinking about recurrent brain metastasis, brachytherapy could be considered. Is it the same idea for primary CNS malignancies that you really only reserve it for those sort of salvage patients?
Yeah. I think it's for us, it's either on trial or in the salvage scenario where we don't really have a definite standard of care. So for recurrent glioblastomas, we've been using it with some success. I think it does a fairly good job at providing local control after surgery. And I feel similarly that if you're going through the trouble of reoperating on something, you should consider reirradiating it to consolidate that benefit. So for very localized glioblastoma recurrences, I'll consider it. Glioblastoma is a whole brain disease, but it manifests very locally for most patients. So if they have a manageable size and very local recurrence, then I think it's a very reasonable consideration. It's also been used in the setting of recurrent meningiomas. We haven't done very many of those cases here, but it's a consideration. And then in the upfront setting, we have standards of care developed based on clinical trials. So clinical trial is where that belongs, in my opinion. There is a safety feasibility study called Gestalt that has been done combining gamma-tile at the time of surgery with adjuvant external beam radiation for newly diagnosed glioblastoma, and that's being rolled into a phase 3 randomized study with an OS endpoint called Bridges. So we're hoping to be opening that as well. But yeah, mostly recurrent cases. I think there's a lot of reason to consider brachytherapy for brain recurrences, and then in the upfront setting, we've got to do trials.
Mhm. We'll segue into my portion. Thanks so much for inviting me to present today. I'll be talking about brachytherapy for rectal and anal cancers, primarily focusing on rectal cancer, given the time limits. We can move forward to my disclosures. So I'm the director of brachytherapy at UT Southwestern, and I have some disclosures listed here. We can move on to the next slide. So this is a case of a 63-year-old gentleman with unremarkable past medical surgical history and now presenting with 2-month history of worsening rectal bleeding. No systemic symptoms noted. Essentially, blood work is unremarkable, and he undergoes a colonoscopy, which shows an ulcerating 4-centimeter mass noted in the anterior right wall of the mid-rectum, approximately 6 to 7 centimeters from the anal verge. Biopsy confirms moderately differentiated adenocarcinoma without LVI, and MMR status is intact. Baseline CEA is elevated, and what we can tell from systemic staging is that there are no distant metastases, and it is classified as a clinical T3 and 0 EMVI negative, CR negative cancer. And so this patient actually elects to participate in the ongoing phase 3 Morpheus trial. And this diagram illustrates what the trial is currently randomizing patients to. This is a selected group of patients at T2, T3, and 0 tumors, less than 10 centimeters from the anal verge, less than 5 centimeters in tumor diameter. And patients all undergo concurrent chemoradiation to 45 gray with capecitabine. And then they're randomized to either EBRT boost or HDR brachytherapy boost. All right. And so as a preface to the Morpheus trial, there's a trial that was published with full mature results now in Annals of Oncology. This study was called the OPERA study. And it was a very similar study design, but instead of a HDR brachytherapy boost, they were using a contact X-ray brachytherapy boost in this trial. And so we're going to go through 2 poll questions. So question 1 is, what is the 5-year organ preservation in the contact X-ray brachytherapy arm, which was the experimental arm? Troy, I'll let you finish the poll when there are enough answers submitted. Okay, great. So the correct answer is actually 79% in the contact X-ray brachytherapy arm. And then what was the 5-year organ preservation rate in the EBRT arm? All right, and I think the majority got the correct answer. So as you can see, with median follow-up of 61 months, we are seeing a pretty strong signal, which has dramatically shifted the guidelines in Europe, given that they have access to contact X-ray brachytherapy. We can move on to the next slide. So currently, just to give you guys some context, contact X-ray brachytherapy is pending FDA clearance. Sorry, clearance would be a more accurate word than approval. It's expected to get clearance sometime this year, which is exciting. If you have a chance to take a look at the device online, it is a little bit restrictive in terms of tumor size. Typically, the lumen of the contact device is about 3 centimeters, although the OPERA trial allowed tumors up to 5 centimeters in diameter, with the hopes that they would start shrinking with the EBRT at the start of the treatment. And it is also pretty short, so you have to look at pretty distal tumors to be able to apply this contact X-ray device. Currently, HDR brachytherapy, which is iridium-based, as you all know, is available in the US. Electa has actually acquired Zoft Accent, the electronic brachytherapy equipment, which has some endorectal applicators that would be compatible with a contact X-ray-like treatment boost, but it's not currently marketed towards that particular indication. And so for HDR brachytherapy, most of the published literature looks at multi-channel applicators, either something like a rigid vaginal applicator or something more flexible that will be made of silicone, with a central tungsten shield, which we're going to look at in a couple of slides. And from a workflow perspective, especially when starting a new practice, I would anticipate generously a good 2, if not 3 hours per fraction, just to make sure your team is entirely available for that time. And at our institution, we needed to develop an in-house product in order to support the program, given a temporary transient shortage of elective flexible applicators. They actually just got their FDA clearance last month, so we're expecting to receive their commercial product next month. And so we've had to adjust our supplies to allow for MR simulation workflow, which I'll illustrate in a few slides as well, so that we could have better targeting accuracy versus CT sim-based planning. All right, moving on to the next slide. And so in our current institution, essentially, we're implementing the Morpheus trial, so patients are participating on it, and also looking at patients who've had prior treatment, essentially planned watch and wait or planned organ preservation with prior, regular doses of ABRT, now presenting with a slight regrowth. And so our treatment regimen consists of 3 weekly HDR brachytherapy fractions, prescribed to a dose of 10 gray per fraction, no PTV expansion. And as you can see, I know my mouse pointer is not going to illustrate, not going to follow the slides here, but we do have a silicone applicator, which is that mint green color on the right-hand side. It's a poured silicone, and it has a central channel that's currently filled in with plastic on that illustration. That allows us to take images without all the imaging artifacts of tungsten. And so while we are finishing optimization, that central hollow channel gets filled with a tungsten rod to allow shielding of the contralateral rectal wall. And so the actual commercial product from Electa looks a lot like this. It's actually more translucent and slightly longer, which allows easier clamping of the device at the end of the table where the patient's getting treated. We can move on to the next slide. And so just so you guys get familiar, with these types of approaches, there is a need for real-time endoscopic evaluation, especially if you have access to CT-based planning for, real-time volume delineation. It also allows you to clean up the area if the patient's bowel prep was inadequate. And in exceptional cases, if there's a stenotic access, you'd have your GI or colorectal surgeon nearby to use a guide wire as an exchange system to actually advance your applicator within the rectal lumen. It also allows you to assess the tumor between each fraction because, unsurprisingly, these things respond quite well and pretty rapidly. And so if your volume shrinks, you'll actually be able to assess it with greater confidence on endoscopy rather than CT. So they're complementary imaging modalities, right? Direct visualization and axial imaging. Next slide. And so in terms of things to think about, from a patient standpoint, we can actually click on the right mouse so that everything shows up. Essentially, you're going to instruct your patient to prepare with 2 fleet enemas. And especially if you're planning sedation, given the duration of each treatment fraction, there are some fasting instructions that have to be signed off to the patient before they present for their treatment. Next slide. All right, I acknowledge the slice is a little bit small, excuse me. But in essence, there are some standardized workflows to allow seamless coordination of staffing with both nursing therapists, physics, and radiation oncology, and or GI or colorectal if you have them involved in your multidisciplinary team. But this essentially illustrates what happens between timeout and the actual rectoscopy followed by rectal applicator insertion and then optimization. And move on to the next slide. I think it's illustrated a little bit more broadly. And so essentially in our clinic, what we do is we'll position the patient on the Zephyr, do the timeout in the HDR vault. Our endoscopy is in the HDR vault. We'll document the tumor location, dimensions, and do a little bit of suctioning as needed. Following that, we'll insert the applicator, which has two balloons, which I'll illustrate on the next slides. And you have to make sure that your balloons are oriented to both compress the tumor to make it as flat as possible. And also there's a contralateral balloon that will act as a space. As Tom mentioned earlier, the inverse square law is important to note for brachytherapy. So if we're trying to boost something small and spare the rest of the rectum, we're going to add a saline balloon on the other side to move the healthy rectum away. And then once that applicator is inserted, we can use the same Velcro underwear that you might have observed in GYN brachytherapy planning. After that, we'll proceed with a CT scan. With multi-channel identification. Typically, our therapist will have inserted some index wires, which are also known as the keloid wires within those channels. There's a specific wire that helps us identify the first channel out of all 8 so that we don't get disoriented in space. Once that's done, we'll proceed with an MRI, which is literally next door to our HDR vault. Once the MRI images are acquired, there's essentially dual work between a physician and physicist to contour both the applicator, the tungsten central channel, and then the CTV. And then while we're finishing that up, the therapist move the patient back to HDR. We'll connect the required channels, the ones that we will be using for treatment. It would be exceedingly rare to use all 8. And then add the tungsten shield at that time, and then plan, treat, deliver, remove the applicator, deflate the balloons before removing the applicator, and then proceed to the procedure debrief. So all of this, essentially, if you're doing CT-based planning, takes about an hour and a half, 2 hours. If you add the MRI workflow in there, it could be a little bit longer than that. And so this illustrates what the double balloon technique is intended to achieve. Essentially, if you have an ipsilateral balloon, it allows you to basically compress the tumor so that it's not as thick, meaning that you're basically going to be dropping your high isodose lines in the balloon and then depositing dose in the tumor with a lesser dose gradient, right? Because we're actually trying to spare the rectum. And so we do appreciate some heterogeneity in HDR brachytherapy, but we do try to limit the surface dose to about 20, max 30 gray in certain points. And then on the contralateral side, you'll notice that there's an even larger balloon. It really helps secure the setup so that this device doesn't just slide out. And it also distances the healthy rectum so that our dose doesn't actually land inside the contralateral healthy rectum wall. I think my next slides illustrate the first, the patient demo that we were describing, the case we were describing initially. Oh, and so Troy, if you can head back one slide and just hover your mouse over the image, you'll see a little play button that should be launching. Oops. There
It
isn't a...
is possible that may have gotten lost in the transition. I'm sorry.
That's okay. If you'd like, I could try to share my screen. Would the Zoom allow me to do that?
Sure, we can give it a shot. We got some time.
Just a second. One second. Something else. Okay. One more. Not optimal, but we will do what we can. Give me a sec. Yeah, it's not letting me get the joys of having 2 monitors. Give me just a second. I'm going to just use the basic PowerPoint slides so we can run through the video and put this together. I think it helps to really illustrate what we're trying to do. Okay, let me know when you can see my screen.
I can see it perfect.
Okay, so this is just kind of a video scrolling through the actual dose distribution of achieving good tumor coverage with our CTV. and good sparing of the contralateral rectal wall here. Can you guys see the video?
Yeah, this is excellent. Thank you.
Okay, perfect. Sorry, not the best format, but in any case, this was the patient's second fraction. So again, same approach. The balloons, as you can see, are oriented diagonally to match the orientation of the tumor, and we're displacing the healthy rectal wall at each fraction. That third video is essentially same illustration with the video, and then we're going to go back to Troy's slides. I'm going to stop sharing my screen. And let me know when you're able to share your PowerPoint again. Okay, here we go. So yeah, between fractions, I just took some representative MRI screenshots because we have the luxury of MRI with each fraction at our institution. And you can see that just on basic axial T2 images, we're already seeing that there's interval response between fraction, most notable between fraction 2 and fraction 3. So being able to reduce your CTV volume with direct visualization and real-time imaging is super helpful. Next slide. These are some representative images of post-treatment MRI showing significant reduction in disease volume with a post-treatment radiation ulcer on the right-hand side endoscopy. This was in the first few months after treatment. And then next slide. And this one actually has a long-term follow-up endoscopy, and you can see traditional telangiectasia within the rectal wall at the treated site, but very clearly patient in complete clinical response. Moving to the next slide. I just wanted to insert, for the sake of time, a quick commentary on brachytherapy for anal cancer. You know, the data for brachytherapy for anal cancer is more scattered, none of which is prospective, and it spans about 4 decades of data, mix of LDR, PDR, and HDR eras. And it really ranged from interstitial and cylinder-based approaches. I think in the general community, there's still a lot of critique about proper selection for anal cancer, brachytherapy at large, due to excellent outcomes with standard chemoradiation and even ongoing trials exploring the use of de-escalated therapy. So not currently included as a standard option in most international guidelines, but I just wanted to highlight some very pertinent review articles that really go over some of the potential indications you may encounter in your practice. And for the most part, we're going to be doing off-label use of applicators that are intended for other disease sites for these types of scenarios. So thank you very much for your attention. Sorry for the video hiccup, and happy to take any questions. All right.
I have one question actually. Clearly there's benefits to using a brachytherapy boost over an external beam boost when you're thinking about sparing nearby OAR, small bowel, bladder, things like that. Are there concerns for additional toxicities related to brachytherapy boost that you wouldn't expect from external beam, specifically in the target site in the rectum?
That's an excellent question. I think that's part of the reason, that the HDR trial is ongoing. Essentially, in some of the older data that was done prior to the activation of Morpheus, there were some cases of late stenosis of the contralateral rectal wall, which can cause some symptomatic sensation like you're having more narrow stool caliber and a little bit more straining to move your bowels. So these are the things you would notice later on, probably in that 2 to 5 year window rather than the first 2-year window. And on the registry that was previously reported by McGill, which is where I initially trained, there was a registry of elderly, inoperable, comorbid patients, many of which were on either antiplatelet or anticoagulation therapy. And there was a rate of approximately 25% late rectal bleeding. None catastrophic, none requiring, hospital admission or surgical revision, but still intermittent bleeding that, looks like blood in the stool from time to time, or blood on the toilet paper, or blood in the toilet bowl. And that's something to note, I would say, is the number one thing to be aware of when looking at organ preservation. And so, yeah, those are the top two. In terms of delayed bladder toxicities or vaginal toxicities, we'll be waiting for the long-term results from Morpheus to really report on that.
Excellent. Also, one other question came up in the chat by Caitlin. Given that it can be a lengthy process for patients, are there ever concerns of needing anesthesia or ever the need for that?
Yeah, absolutely. Great question. I would say the vast majority of patients do well with moderate sedation. So at our institution, it's typically a combination of midazolam, an IV muscle relaxant, and IV painkillers. And patients typically will fall asleep somewhere in the middle of the procedure just because it takes time. In some patients where they're having pain to begin with, which could be disease related, if you have the resources to achieve general anesthesia for your caseload, that's something to keep in your back pocket. But for the most part, patients can tolerate with moderate IV sedation.
Perfect. Thank you so much, Dr. Grant. That was an excellent talk that moves us nicely into the next talk from Dr. Nagavi. Go ahead.
Hi, my name is Dr. Nagavi. I'm the program director for the Brachytherapy Fellowship at Moffitt Cancer Center and the section head for sarcoma in the Department of Radiation Oncology. I'll just give you like a little nod, Troy, because I know there's a bunch of... So let's go over a little background. Soft tissue sarcomas are rare. They're of mesenchymal origin. They're made of 70 or so distinct subtypes. Local therapy options predominantly include surgery alone. Go ahead. Yeah. And with surgery alone, the larger the surgical extent, though, the better the local control, but the increase in toxicity. The larger historically, they used to do these large amputations. Obviously, patients didn't appreciate the amputations. Go ahead. And then comes external beam radiation. With external beam radiation, we're able to do more limb preservation and improve local control. And there were studies, randomized studies, where it showed that the inclusion of radiation improved local control by about 30%. I think some of the figures aren't showing up. Go on. Yeah. So, yeah, so maybe it's a little lagging. So you have what's called a pseudocapsule. The tumor's not encapsulated the way that a lymph node is. What'll happen is that as the tumor is trying to grow, the immune system is trying to wall off the advancement, and it creates this fibrous husk around the tumor. But unfortunately, there's microscopic disease up to 4 centimeters beyond the pseudocapsule. And so when they remove just the pseudocapsule, the chance of recurrence is still relatively high. With external beam radiation, we traditionally do 4 by 1.5 centimeters to include this peritumoral edema, and that usually creates the CTV for external beam. With brachytherapy, our volumes are much smaller. So we do 2 by 1.5 centimeters. The control rate is still very good. Dr. Harrison had a trial back in the 90s where the control with high-grade disease improved up to 90% compared to surgery alone at 65%. The benefit of brachytherapy is that it does not penetrate much, so the conformality is there, but it's also a detriment because it doesn't have as much penetration in cases with closer positive margins or unplanned excision where you're worried about tumor seeding or microscopic disease. It may not be able to push dose deep enough to offer as good a local control. Next slide. So we have a patient that comes in, 63-year-old, former smoker with type 2 diabetes. Their chief complaint was they had this grape-sized mass in their left arm, thought it was a pulled muscle. It started to get more swollen and tender with some numbness. They come in on physical examination. You see this 6-centimeter mass in the anterior compartment that's tender to palpation and with flexion of the arm. The mass is restricted with elbow flexion and extension, which is important. It helps you determine if the tumor is deep or superficial. There was overlying mobile subq and skin was intact, again, suggesting that it was a deeper tumor. And then there was numbness along the lateral thumb, suggesting that the radial nerve is either compressed or involved. So what do we do next? Anytime you have a soft tissue mass, an MRI is the most important in helping differentiate soft tissue. In this case, the MRI showed a 6.9 centimeter intramuscular mass in the brachioradialis. When doing an MRI, the sequences that are the most important are your T1 post-FAT-SAT. This will help you visualize gross disease. The T2 FAT-SAT will look at peritumoral edema, which helps you with your CTV. And then your T1 non-FAT-SAT will help you look at normal anatomy, such as neurovascular structures. Now, this patient had a biopsy. They had an excisional biopsy in 2021, which showed a 7 centimeter myxofibrosarcoma grade 3. This is not ideal. Ideally, you want a core needle biopsy because sarcomas can seed. They are notoriously for having tumor seeding. So if you do an incisional biopsy, they have to be careful of hemostasis to mitigate contamination. But an excisional biopsy or an unplanned excision has an even higher local recurrence risk because you don't know how much they're surgically manipulating the area. So all that instrumentation makes it to where it's really uncertain the depth in which the microscopic disease may have been embedded. And then in addition to that, staging. We're always going to want to get a CT at the least of the thorax when concerned for sarcomas. Looks like the images aren't coming up. Yep, there it is. What would you recommend after an unplanned excision? So again, we're worried about depth. So move on to the next slide. You can see that because of this, we started with neoadjuvant radiation. Standard fractionation, 50 grain, 25 fractions, with the volume expansions we talked about, 3 to 4 centimeters by 1.5. And essentially, patient then went to surgery 3 to 6 weeks later. At the time of surgery, there was no residual disease. Great, success. But at follow-up, within a year, the patient had 14.5 centimeter biopsy-proven recurrent disease of the brachioradialis. Next slide. So plan for treatment now. Patient now has a rapid recurrence after previous radiation. Would we do resection alone, resection plus brachy mono, or resection plus another course of radiation? Great. All right. So the reason why, what we would do in this case, move on next slide. So resection alone, that recurrence rate is very high. And I've included QR codes for the manuscripts, that a lot of which we talk about, the ABS guidelines, and some of the studies that we'll be talking about. If you guys are interested, you can always take a picture. Resection alone, really high recurrence rate. If you do external beam, again, it's great for improving local control, but has a severe complication risk, especially within a year of prior radiation. Brachy monotherapy is somewhere in between. It can help the local control. The severe complication rate is a little bit less. So the ABS guidelines recommends reirradiation of 30 to 50 gray monotherapy. Keep going. So patient went to surgery. They had a wide local excision, showed a 13 centimeter grade 3 myxofibrosarcoma. Margins were close, and patient underwent brachy monotherapy. So brachy monotherapy, we did what's called a delayed reconstruction, which is a wound vac, acts as a temporary closure. They then had radiation, 36 gray and 10 fractions BID. The delayed reconstruction, basically what's happening is you put a wound vac in place when after the catheters are placed, patient goes through radiation, and then after the radiation is done, before the reconstruction is performed, they assess final margins, the catheters are removed, and then when all that is clear, then they'll do the delayed reconstruction. In this case, they did a left anterior lateral thigh free flap. So principles of brachytherapy. What's important is that they obtain an en-bloc wide local excision, identify the areas at risk. So you go in with the surgeon, they'll resect out the area. It's really a collaborative effort because they'll show you the areas that are at risk, the areas where they really had to cut it close. They'll put surgical clips to help guide you on your CT simulation. And it's important for us to identify adjacent OARs. In this picture, it's kind of going a little bit fast, but you can see in this picture, you see my finger pointing at the radial nerve, which the radial nerve the tumor was right up against it, and there was a positive margin or very close margin on that radial nerve. You want to do a single plane of catheters, so about 1 centimeter apart, parallel to the wound, and away from the insertion of the catheters at the skin surface. So at least 1 centimeter from where those buttons are that you can see. You're sewn in with absorbable sutures. The buttons at the ends anchor the catheters so that they don't move, they don't shift. And then the closure can be either immediate reconstruction or a delayed reconstruction. Immediate reconstruction is the traditional technique. This is what majority of the earlier data is on, where catheters are placed and there's a flap or a closure done immediately. In those situations, you have to wait a minimum of 5 days because in those first 5 days, you have fibroblast regeneration, and you can stun that and create wound healing issues. So if a person is getting immediate, you have to wait till post-op day 6. Now with staged reconstruction, it's slightly different. You're using a temporary closure, oftentimes a wound vac. That wound vac now acts as the closure to prevent infections. Post-op radiation can occur as soon as day 1. So you're not worrying about a healing wound. In a staged, that wound vac helps pull nutrients because of the negative pressure. So it helps with wound healing. It also helps improve oxygenation. And so with those, you can have improvements in local control and toxicities. Plus, it buys you time. In the study where we compared staged reconstruction with immediate reconstruction, what we found was the patients that had a positive margin on initial resection, but then had time to go back and re-resect after the staged reconstruction, had local control similar to an upfront negative margin. And so it buys us time. And in the study, we actually showed that on multivariate analysis, the only thing that predicted for improvement in local control and limb preservation was the staged reconstruction approach. And the QR code's at the bottom if you're interested. Next slide. So procedure details. Here's just some materials that you guys could use. Trocar, I prefer bent and beveled. It's, the sharp ones can actually pierce through nerves and vessels. Non-sharp pickups, the marker is to help delineate where you're going to insert the catheters through the skin. A ruler to make sure that you have your spacing correct. You don't want them more than 1 centimeter apart. Otherwise, you'll end up with a lot of hot and cold spots, especially with HDR. Sutures, you want to suture the catheters in place in the tumor bed with absorbable sutures like Vicryl. And then you also want to anchor them to the skin with something that's non-absorbable like silk. We use 6 French catheters that are either single button on the left. The ends are placed deep within the tumor, or you have your double button, which means that it comes in through the skin, goes through the tumor bed, and comes out through the skin. It's much better anchored, but not always possible, especially if you need to treat deep. Okay, next slide. Now, principles of brachytherapy. So what's important is you first are going to get a CT simulation. You use the CT scan to help you digitize the catheters. The clips will help you outline the tumor bed and aid with planning. The wire, we place a wire around the wound edge so we know exactly where that wound edge is so we can minimize the dose to it. And oftentimes we'll fuse the pre-op MRI to help us delineate where the neurovascular structures were and also give you a rough estimate of the extent of disease. And then radiation planning. So historic data, the one I showed you about the Lou Harrison trial was LDR. It used iridium-192, but it was left in for 5 days. And so LDR is 40 to 200 centigrade per hour. We primarily use HDR, which is 1200 plus centigrade per hour. It allows us to really have more customization of dose delivery. Now, brachytherapy is the original SIB. You have high doses to the area at risk. Right where the catheters are, you get much, much higher dose with a rapid dose drop-off to adjacent structures. Your catheter placement is key because if your catheters are more than 1 centimeter apart, you end up with cold spots and hot spots to try to cover that dose. And so try to avoid 150% isodose line overlap and direct catheter placement over OERs. And on the right, you can see here's a case of a calf. You try to avoid the neurovascular structures, and then you try to mitigate the overlap. Lastly, treatment planning. You have a radioactive isotope in the afterloader on the left. It then has a wire that feeds the high-dose seed through each of those catheters, stopping at different points in the dwell positions. And treatment's less than 30 minutes, and it's BID. Afterwards, you remove the catheters. You can do them either as an outpatient, or you can do them at the time of the delayed reconstruction. Next slide. So in this case, just go over some constraints and dosing considerations. So what's important is, first off, the CTV coverage. You want your CTV coverage to be around 95%. Go ahead. So you can see here's the wound vac, there's the elbow. CTV coverage, we want close to 95%. Keep going. The nerve. Now, in general, you want to have your nerve, mitigate your nerve dose to about 30 gray, because remember, we're hypofractionating and accelerating. But in this case, because the nerve was involved, you can go up to full dose and try not to exceed 50 gray. And you can see the radial nerve sits right below where we're trying to treat. Continue. The wound vac, we still wire the edges of the wound vac, which help us determine exactly where the skin or the wound edge is. So we try to minimize the amount getting 100% so that when they go back to put the closure, that area hasn't seen a lot of radiation dose and can heal properly. Continue. Okay. So what if this patient had never gotten radiation the first time and they come back with this 14 centimeter grade 3 recurrence? Would you do re-resection alone, resection plus brachy mono, or EVRT and a brachy boost? Good. So again, re-resection alone in a recurrent sarcoma, the recurrence rate is really high. With brachy, again, you can improve the local control to about 65 to 90%. But again, when you haven't had radiation in the past, you're more worried about pushing the depth in which you can treat. With external beam plus brachy, you get the benefits of both. Your external beam allows you to really penetrate dose, and the brachy allows you to really dose escalate in the areas that matter most. And in studies where they've compared brachy boost and brachy monotherapy, a boost had improved local control for stage 3 disease and grade 3 disease. So for the ABS guidelines, if a person has never had radiation before for a large tumor or recurrent tumor, we recommend combined therapy. Now, what if you see how we noticed that there was an exposed radial nerve? So what would you do to help with catheter placement? Would you place the catheters directly over the nerve, place them over a centimeter apart, or create some kind of spacer over the nerve? Right, correct. So again, you don't want to place catheters directly over the nerve. You guys know that nerves are serial structures, and so hotspots really matter. You also don't want them over a centimeter apart because you're underdosing an area where you know there is disease. So one of the things that we created was something called a vicral mesh. We take a vicral mesh, we fold it onto each other to create a cushion. We then sew it over and anchor it over a neurovascular structure. Oftentimes, you can't sew a catheter directly on the neurovascular structure. And so this not only acts as a spacer, but it also acts as a scaffold. So then when the catheters are sewn into the mesh, now they maintain their position in the tumor bed and don't shift between fractions. So in conclusion, for brachytherapy, monotherapy can be important. It can improve local control versus surgery alone. It can help mitigate toxicity in the reirradiation setting because of the conformality. For brachytherapy boost, the EVRT allows for the low dose penetration, but the boost allows for a conformal dose escalation, which translates to an improved local control for high-risk patients, stage 3, grade 3, or close positive margins. A delayed reconstruction technique allows for increased blood flow, potentially creating more oxygenation, increasing the radiation sensitivity to the tumor. It can also help with healing. And in our studies, had a significant improvement in limb preservation and local control. OER involvement, attempt to use different meshes that will allow you to act as both a spacer and a scaffold so that you can maintain the position of the catheters and maintain your distance from the neurovascular structures. Thank you. I made Troy really have to work with all those button presses, huh?
I feel like I figured out your pace by the end of it, but yeah, you certainly made me work, and I appreciate the talk. Any questions? Throw them in the chat or unmute yourself. I have one question. So, this procedure, sarcoma brachytherapy, there's clearly sort of a surgical element here, and there's definitely more surgery, I think, involved than maybe a typical radiation oncologist is used to. How do you get yourself to the level of comfort doing this procedure, and how closely do you end up working with the sarcoma surgeons sort of throughout this whole process, both planning and execution of the procedure?
Yeah, so I think it really just requires repetitively doing them. So the way it works normally is the surgeon will do their portion. They'll resect out the tumor. They'll leave the tumor bed open. I will join them at the end of their case. They will show me the areas they're concerned about. They'll put clips in the areas they're concerned about. And then I will take over and I will do the trocar and catheter placement. So, I think one of the key points that Dr. Harrison really pushed for us is that as brachytherapists, it's important for us to be the ones to position those catheters because we're delivering the dose. And so it was really kind of embedded into us to be accountable for where those catheters are and to game plan out exactly what you need to do to avoid those structures, because in your mind you know exactly how much dose you can penetrate. For example, if you need to treat deeper to where that muscle is, then you need to weave the catheter in deeper into that muscle so that your penetration of dose is even deeper than that. If you see a structure that you're worried about, then again, creating scaffold and your catheter positioning is key. So it's important to really get practice in there. And if anyone's ever interested in doing sarcoma cases with us, they're always happy to come and do a rotation. Or I think there's even some lectures that I gave online on the step-by-step on how to do this procedure.
Excellent. And we're almost at the top of the hour. So one last question here from the chat. Aaron asks, what is the external beam dose when you do brachytherapy boost?
Yeah, so in general, the microscopic dose is a minimum of 45 gray. So anywhere from 45 to 50 gray, that's going to be your low dose volume. If you're doing regular external beam, if you're doing brachy. The boost is traditionally anywhere from 16 to 20 gray. You want to go between 3 and 4 gray per fraction BID. And if you think about it, the dose is much higher than what you normally would see with external beam. But because of how it's dose escalated, it's very conformal. So you have less risk of fibrosis and essentially dose smearing to a larger volume.
Well, perfect. Thank you so much, Dr. Ngavi and all of the panelists here today. This was an excellent session. These are topics that, as a trainee myself, we often aren't thinking much about. We think about GYN, we think about GU brachytherapy, but these are certainly important brachytherapy topics as well for us to at least be familiar with and potentially to grow in our own practices. So thank you all for giving these talks. I just wanted to end with this slide here. ROVER is also growing, just as brachytherapy is growing. Our educational programming is growing, and we're always seeking new members of the team. We're looking for additional ROVER resident moderators to join us starting this fall. So if you're interested, the QR code for the application portal is here at the bottom of this slide. We'll be taking applications through the end of May, so plenty of time to sort of talk to us and consider this option. But we'd love to have you as part of our team. And with that, I will end the session. I'll leave this slide up for a moment so y'all can capture this link. But feel free to bring up any other questions or topics as we close the session up, or you guys can sign off. Thank you guys for joining.
Thanks for having me. And if you guys have any questions, you can always email me, arash.nagavi@moffitt.org. I'm happy to answer any questions you guys have.
Thank you.
Thanks, Troy.
All right. Thank y'all. Enjoy the rest of your afternoon and enjoy your weekend. Take care.